My name's Rohan Jagathesan. I'm a consultant cardiologist. I work out of West Essex and East Hertfordshire and Pan Essex out of the Essex Cardiothoracic Centre, which is based in Basildon. I also have an honorary contract at Barts in the London Chest. So I work the whole region. I am currently the divisional lead cardiologist at the Cardiac Centre, and I'm also the chair for the Essex Chair in Cardiology for the Essex Strategic Clinical Network. I work as a general cardiologist and have interests in intervention and percutaneous aortic valve replacement. There are two main areas that I'm involved with screening for heart disease. Screening of young individuals for sudden cardiac death and screening for middle-aged and slightly older patients for the development of arterial disease. If we consider the young group, most young people who undertake competitive sport are at risk, may be at risk of sudden cardiac death. So this is obviously a great concern, and we see this rather unfortunate incident occur from time to time in the United Kingdom. We've seen it in sports people, in football and marathon runners that have been in the newspaper recently. A screening program for this would involve a cardiologist seeing the patient, doing an ECG and doing a heart scan. And this is recommended in the United Kingdom by the big organisations, but isn't funded in the United Kingdom, and therefore it's somewhat ad hoc. In Europe and America, people that undertake competitive sport will always have a medical before they're allowed to participate. And as a consequence, I think that there is a need there and an opportunity there for us to try and deliver a better service. In the United Kingdom, we as doctors look to treat individuals who are at risk of developing problems, and this is something called primary prevention. And in the UK, because it's a health service, this is often done in a population way. So you'll go to your GP and he'll put a number of numbers into his computer, and out comes a percentage, something called a Q risk score, which tells them the probability of you having a heart attack over the next 10 years. And in the United Kingdom, if that number's over 20%, you're told to take a statin and possibly consider aspirin. If it's over 15%, often diet and lifestyle is recommended. If it's over 10%, diet and lifestyle is discussed. In America and Europe, over 10%, statins would be treated. And a lot of the differences that occur between ourselves and other health sub-economies are because of funding issues. The problem with the system is that the actual algorithm that calculates this is based on things that are not all that modifiable. So you score badly if you're a man and you score badly if you're older. Then there's smoking, diabetes, cholesterol and high blood pressure, which we all worry about, an element of obesity, which obviously is a current health concern. But the thing that's not included in this is the family history and the implication of family history or ethnicity, and also to a certain extent social deprivation that may or may not be associated with this. And it's been calculated that family history can increase your risk by up to twofold. So if you scored 15% and you had a strong family history, the process could be 30%, and you're falling between stools for treatment. And the problem with population calculations is that often your GP will click on a button and say you should be on a statin, but nothing specifically is discussed about why, other than a number. And therefore I have a specific interest in determining individual risk profiles. And we can now do that with something called coronary calcium scoring, which is a very straightforward test, has about the amount of X-ray radiation as a chest X-ray, and takes about 5 minutes. And that tells me whether or not you're furring your arteries or you're not furring your arteries. And it tells me whether the cholesterol is being deposited in your arteries or not. And if the cholesterol is being deposited in your arteries, then obviously the cholesterol is too high and it needs to be lowered. And if cholesterol is not being deposited in your arteries, then there is no need to worry about that at this moment in time. So this is akin to the concept that a 15-year-old boy who has a cholesterol of 8 doesn't fur his arteries at 15, but a gentleman at 65 who has a cholesterol of 6 will suddenly start filling his arteries. And why? Why does that happen? And well, it's because of the vascular integrity. It's to do with the endothelium or the aging of the arteries. So at some point there's a breach in the arterial wall integrity and the cholesterol gets deposited. And at that point, statins will make a difference. At that point, lowering cholesterol is going to reduce the event rate. And at the moment, we can see that a lot of clinical studies show that the outcomes on those patients is where you get your best bang for your buck, for want of a better term. But on an individual basis, it's very easy for patients to understand that if I'm now furring my arteries and you've looked at my arteries, then clearly I should take tablets. So this is a much better and refined way of treating for primary prevention. So that's primary prevention, and I have an interest in that area. But in terms of secondary prevention, what we know is that if you've had a heart attack or you've had stents put in or you've had a bypass operation, we then give you a whole bundle of tablets. Aspirin, cholesterol-lowering tablets called statins, beta blockers to slow your heart rate down, because we know slower heart rates are associated with better outcomes, and drugs called ramipril, which lower your blood pressure and improve the remodelling of the heart. And in fact, if you look at the clinical studies, there are 15 or 20 tablets that potentially have benefit, but you get a reduced benefit once you go beyond 5 tablets. You get not as much gain as you add 6, 7 or 8. So we use a core of 4 or 5 tablets. Now, what it does appear is that there are 2 groups after having a heart attack. There are the group that actually do very well, and these tablets are enough. And there are the group that don't do quite so well. And that group, generally what is done at the moment is that in the UK, we just watch people. And if they have another event at 3 years, then we intensify treatment. So after you've had a heart attack and you've been treated, we quote a 15 to 20% chance of having another cardiac event in 3 years, and as much as a 30 to 40% at 5 years. But actually what's happening is that a small cohort are having the events and the rest are actually quite well. And to identify that group, you can do vascular screening, which involves a whole plethora of blood tests that are done in the United States that you'll be able to read about on the internet, that include highly sensitive CRP, ApoB and ApoA ratios of cholesterol, lipoprotein small a, and homocysteine, for example. And these things allow us to optimize or intensify specific statin treatment to try and make things better. It's a bit like fine-tuning. And although we don't have all the outcome data to say that this definitely makes a difference, what we do know is that if you are going to get benefit from a statin, and if we do this and we can fine-tune it for you to be potentially on a better statin, then actually you've got nothing to lose and you've potentially got something to gain. So again, I have an interest in this, particularly in young people. So I have a lot of young patients of 30, 40 and 50 who've had heart disease early. And of course, they're going to run into trouble because their life expectancy is still 80, and I've got to worry about them for the next 30 years. So we've got to get it right, and I feel very strongly that we have to get it right, and therefore we should do this early in the process. In terms of coronary stenting has moved forward substantially over the last 15 or 20 years. We now have drug-coated stents that are probably, we would consider, 3rd generation, that work almost as well as bypass surgery and have a longevity that would appear to be out to 7-10 years, which is similar to vein graft patency. A lot of patients ask me about how long stents last for, and I often say to patients that the risk of stent re-narrowing is in the first year, and that risk is about 1 or 2%, and if it doesn't re-narrow in the first year, then the longevity of it is that it is so good that you're likely to develop a problem in another area of your heart arteries rather than in the stent. Okay, so the technology is excellent at the moment, but the technology is moving forward. And the great area of interest at the moment, and we're involved with their registry study at the Cardiac Centre, is bioabsorbable stents. So stents were metal and have a drug coating. These are now not metal, they're polymer stents. They're more difficult to put in, but we have been putting them in with great success. And what happens is that the drug secretes over the same period of time, and then over 2 years the stent disappears. So the stent is absorbed and there is no metal in your arteries. And that of course makes it easier later on if we ever need to go back and do anything. So that's in its first generation, and that's the next area of great development in stents, which will take us further forward. I co-run the TAVI program, which is the percutaneous aortic valve program, which I'll explain in a moment, with my colleague Mr. Birdie, who is working with sutureless aortic valves, two new technologies in treating people with aortic valve disease. The TAVI program is an opportunity to do aortic valve replacement through a minimally invasive route through the leg. At the moment it's in its first incarnation and is licensed for people who are too high risk for open surgery. And the reason for that is that there are slightly higher risks associated with doing it at the moment because it's a new technology, and we don't know the durability of the valve, although we have seen data out to 7 years so far. The Germans are now putting it in people who have moderate risk of surgery as an option, and I think that over the next 2 or 3 generations, over the next 5 or 7 years, we will be replacing a lot more valves through the leg without needing the fact for the chest to be open. So the procedure is very interesting. It involves making a cut in the leg and passing a whole valve, a wire all the way up into the heart, and then crossing the valve, and on top of that putting a balloon through, opening the balloon to fracture the valve and break away the calcification, and then pass the valve all the way up and then inflate it under X-ray control. Usually the inpatient stays between 3 and 5 days, although some of my colleagues have managed to do overnight stay cases, and this really is a great growth area. Unfortunately it's a very expensive procedure, and therefore at the moment it's quite restricted in the health service, but I suspect it will be an area of great growth, and it's a fantastic opportunity of developing newer technologies in heart surgery through a minimally invasive route. As we move forward, cardiac disease remains very important, but there's now a focus on stroke, and we'll see this in the newspapers, and you can have seen this recently, and preventative heart disease. And within the new areas of stroke is the development of identifying patients who have an irregular heart rhythm called atrial fibrillation and treating them properly with blood thinning medication. So traditionally these patients were treated with aspirin, but now the recommendations are to treat them with formal anticoagulation, something called warfarin. And unfortunately warfarin has negative connotations because it requires regular blood tests, it requires you to avoid certain foods, and it's a bit of a nuisance. Although it's very safe and well regarded, for a patient compliance purposes, it's a bit of a nuisance. And new drugs have come on the market, and these have been in the papers recently, the new factor Xa inhibitors and the direct thrombin inhibitors that don't require blood tests, that thin the blood, that are once or twice a day. And these are excellent products, but their assimilation into the NHS is difficult because they're very expensive. They cost about £100 a month, while warfarin costs about £15 to £20 a month, including all the blood tests. And as a consequence, the cost burden to our health service is quite significant. So I've been involved with the introduction of these products into Essex by writing policies as network lead, and I'm very much interested in these products because I think they will substantially reduce the risk of stroke in the future, particularly in this patient group. And I'm also very interested in identifying this patient group, which is also some policy work that I've been doing in terms of pulse screening, where GPs are asked to check the pulse on everybody who comes into their surgery as a matter of routine to identify whether they've got this condition or not and therefore at risk of stroke.